system. So chapter 24, it's about the urinary system. So in the urinary system we have organs like the kidneys, urinary bladder, ureters, urethra, and they have the common function to help us to get rid of excess of wastes and regulate acid-base balance, maintain electrolytes, and help us to keep volume within our body. So the kidneys are located in the peritoneal space, which is the space located behind the peritoneum in the abdominal cavity, with a specific location for the left kidney that extends up to the 12 thoracic vertebrae, from the 12 thoracic vertebrae up to the 3rd lumbar vertebrae. And the right kidney, it is a little bit lower than the left because the hepatic gland or the liver pushes down a little bit. So it can be a little bit lower than that. Now, the kidneys are protected partially by the 11th and the 12th ribs, which are the floating ribs, but also by a muscle that we have between these lower ribs, the 12th rib, and also the iliac crest, which is the quadratum lumborum. Now, superiorly, the kidneys have an organ on the top that is called the adrenal glands, which of course are part of the endocrine system and produces hormones. Another name for the adrenal glands are called suprarenal because they are located above the kidneys. And anytime that you hear the word renal means kidneys. Now, the kidneys drain urine, and that urine passes through the urinary tract, which is made by the ureters, which are paired muscular organs that connect the kidneys to the urinary bladder. And then we have the urinary bladder that serves as a temporary reservoir of urine. And then the urinary bladder drains the urine into the urethra that drains the body into the exterior. So here is the location of the organs of the urinary system. So this is the anterior view. If you remove the peritoneum, you will be able to see the kidneys. They have this pinto bean shape with the hilum facing medially towards the spinal column. And then this is the superior pole of the kidneys that have the adrenal glands in the vicinity, and this is the lower pole. The right kidney, the inferior pole, is lower than the left, again, because we have the liver in here that pushes this right kidney down. So this is the posterior view. Of course, this will be, in this case, the right kidney. This is the left. And then the kidneys drain the urine into the ureters that brings the urine into the urinary bladder. And then here we have the urethra. The urinary bladder, it is protected by the pubic symphysis. So functions of the kidneys: remove metabolic wastes and maintain fluid and electrolyte balance. It helps us also to maintain acid-base balance because it can eliminate hydrogen ions and it can produce bicarbonate and also can prevent bicarbonate from getting lost in the urine. So that's one of the functions of the kidneys. Another function is to help us to maintain blood pressure. Our kidneys produces an enzyme that is called renin that undergoes, starts a cascade that help us to change some molecules like angiotensinogen to become angiotensin 1. So you can start a cascade so that you can control blood pressure when the blood pressure is low. And then it helps us also to produce red blood cells because it produces a hormone that is called erythropoietin. And with this erythropoietin, our bone marrow gets stimulated to produce red blood cells. And then also, of course, detoxify substances from the body, like drugs, wastes, and hydroxylates vitamin D. It's the second hydroxylation of the precursor of vitamin D so that we can have an active form of vitamin D. And it can make new glucose through gluconeogenesis. So those are the functions of the kidneys. For the anatomy of the kidneys, so the kidneys are protected by two membranes, the renal fascia, the renal capsule, and perirenal fat, so fat around the kidneys that are located between, the fat tissue is located between the renal fascia and the renal capsule. The renal capsule is the one, the connective tissue that is in direct contact with the kidneys. And then when someone has loss of fat tissue rapidly, that can lead to drop of the kidneys out of the normal position. This will be called nephroptosis. The size will be 11 centimeters in length, almost, a little bit over 4 inches, by 6 centimeters wide, so like 2.5 inches, and 3 centimeters in thickness, a little bit over 1 inch. So it's like the size of a bar soap. They're very tiny, but they are very powerful. They weigh 150 grams, and they filter a lot of blood, like 180 liters of blood per day. The hilum is facing medially. It has the renal artery, the vein, the nerves, some lymphatics, also some lymph nodes, and the opening of the ureter from the kidney that is called the renal pelvis. Those are all the structures that are located in the hilum. The renal artery, the vein, the renal nerves, the lymphatics, and also the renal pelvis. Now, in the hilum, we have a specific region that is called the sinus, which is the central cavity, that it is lined with the renal capsule and the ureter specifically. And now, this adipose tissue that we have within this region anchors the ureter, the blood vessels, and the nerves as well into their area in the hilum. So if you make a cross-section of the abdominal cavity at the level where the kidneys are, you can see those membranes that protects the kidney and the other tissues that helps to anchor the kidneys into their place. So here we have the parietal peritoneum, and this is the retroperitoneal space. So here is the renal fascia. All of this is the renal fascia. And then this will be the renal capsule. These are the transverse cuts of the kidneys. So the renal capsule is directly in contact with the tissue of the kidneys. And then in between the renal fascia and the capsule, we have the perirenal fat. So this fat, it helps to keep the kidneys into their place. And then the renal veins drains the blood into the inferior vena cava, which is this. And then the renal arteries that provide the blood supply to the kidneys are branches of the aorta, which is this. And then here we have muscles of the back, like the quadratus lumborum, that helps to protect the kidneys. Any questions? Okay. Now, in the cross section of the kidney, or in the longitudinal section, you can see the internal structures, like the renal cortex, which is an area where you have a dark brownish color or reddish, because that's where you have 90 to 95% of the blood vessels, which gives this area that color. And now, the renal cortex surrounds the renal medulla, which is the deepest part of the kidneys. And then in between the renal medulla and the columns of the renal medulla, which extends from the cortex, the columns, into the hilum, we have the renal pyramids. The renal pyramids are triangular, almost in shape, and they have many of these tubules that collect the urine and to bring it into the first part that is going to form the ureters, which is the renal papilla. Now, in the renal cortex and also in the renal medulla, we have processes for making urine, which is filtration, which is reabsorption, and secretion. So, the functional unit of the kidneys are the nephrons. And we have two types of nephrons. The nephrons that are located in the cortex, which will be the cortical nephrons. And then we have the nephrons that are located close to the medulla, which will be the juxtamedullary nephrons. Now, the nephrons have parts. It has a part that it is made out of capillaries, which is the glomerulus. So this part will be the corpuscle. The other part is just tubules that runs out of the corpuscle that are called the renal corpuscles. Now, the pyramids have collecting ducts coming from these tubules, the renal tubules, that are going to drain the urine into the tip of the pyramids that are called papilla. And then this papilla is going to drain the urine into a cup-like projection that is called the minor calyx. And then 2 or 3 minor calyces will join, will merge, forming the major calyces. And 2 to 3 3 major calyces will merge, or anastomose, forming the renal pelvis. So here is the internal anatomy of the kidneys, the gross anatomy. So here is the capsule. And underneath the capsule, we have this reddish brown area, which is the cortex. And internal to the cortex, we have the renal medulla, where you have pyramids, between 10 to 12 pyramids, that has like a triangular shape. So this will be the base, this is the apex, and these are the sides of the pyramid. And then in between the pyramids, we have the renal columns. And then the tip of the pyramids is called the renal papilla. And then the renal papilla receives the urine from the nephrons, and then it drains the urine into these minor calyces. So all of these are minor calyces. And then 2 to 3 minor calyces join to form the major calyces, which are these spaces. And all of these calyces merge to form the renal pelvis, which is this. And it's located next to the hilum. So this is the hilum, and this is the convexity of the kidneys. So this is the superior pole, this is the inferior pole. And in the hilum we have, it's only shown in here, but we have this renal artery, which is branch of the aorta, and we have the renal vein that drains the blood into the inferior vena cava. And then here we have the renal pelvis. If you magnify one of these segments, which will be called lobule in the kidneys, so you have a segment of the renal cortex, the pyramid, and the minor cavity. So this is a renal lobule, renal lobe. So here we have the nephrons, the structural and functional unit of the kidneys. The nephrons have these corpuscles, and they have these tubules. So these are the renal tubules, and this is the corpuscle. In the corpuscle, we have the capillaries that we call the glomerulus. And then these tubules, these renal tubules, connect into these collecting ducts that runs in the pyramids vertically, giving a striated appearance to this pyramid. Now, this nephron that it is away from the pyramid is called cortical nephron, while this nephron that it is closer to the pyramid is called the juxtamedullary nephron. And if you see, the tubules from the cortical nephron are shorter than the tubules from the juxtamedullary nephrons. So that's a difference, an anatomical difference between these nephrons. So the kidneys receive a lot of blood supply. So they receive 1,200 milliliters per minute, a little bit over 1 quart. And the blood that they receive it from the renal arteries, the right and the left. The right provides blood supply to the right kidney, the left to the left kidney. And this is the pathway for how the renal arteries branches once they reach the kidneys. So the renal arteries, they form segmental arteries, 2 to 3 segmentals. And these 2 to 3 segmentals will form interlobar arteries that runs between the pyramids. And then once they find the last part of the pyramid, they make a kind of a curve-shaped turn, and they will be called arcuate because they make like an arch. And then this arcuate is going to extend almost vertically or in an angle, some branches, tiny branches. This will be the interlobular or cortical radiate arteries. And then out of these cortical radiate arteries, you will have tiny arterioles that are going to feed blood into the glomerulus. So these tiny arterioles are going to be called afferent or arriving. And then they will form a tuft of capillaries that will be called the glomerulus. Once the blood passes through the glomerulus, the blood is going to go and drain into the efferent arterioles. Efferent or exiting, if you want to remember it like that. And now, this will feed into the peritubular capillaries that forms a network around these tubules of each nephron. So this is the pathway after the blood passes through the glomerulus. So from afferent arteriole, the blood passes into, this is inside the corpuscle. So once the blood goes from the afferent arteriole into the glomerulus, it will go into the efferent arteriole and then into the peritubular capillaries. And then from the peritubular capillaries, the blood is going to be drained into the interlobular veins and then into the arcuate that follows the same pathway as the arteries. And then the arcuate is going to enter into the pyramids, forming the interlobar vein, and then there is no segmental veins. So the interlobar, they merge and they form the renal vein. And then the renal vein drains into the inferior vena cava. So here is the view of the circulation of the kidneys. From renal artery into segmental, from segmental into interlobar, here in between the pyramids. So these are the interlobars. And then they make this kind of arc, so this will be arcuate, and then they extend to the cortex, so this will be the interlobular or cortical radiate. And then if you magnify this cortical radiate, this cortical area, you will be seeing how from this interlobular or cortical radiate, you form the arriving or afferent. And then this arriving or afferent fits into the glomerulus, and then the blood passes here and is filtering the glomerulus, and then goes into the efferent or exiting. And then from there, the blood goes into the peritubular capillaries that surround these tubules, and then drains into this interlobular vein. And then the interlobular vein drains into the arcuate vein, which now drains into these interlobar veins. And then remember, there is no segmental veins, so all the interlobars, in this case will be 1, 2, 3, 4, forms the renal vein, which drains into the inferior vena cava. Questions about the circulation? Let's play that. I haven't seen that animation. Hopefully it plays it to see what it has. There it is. So that's the circulation of the kidney. Now for the microanatomy of the nephrons and the collecting system. So again, we have two major parts of the nephron, which will be the corpuscle. I mean, some people say corpuscle, but it's corpuscle. And then this is the tubules, the renal tubules. And the renal tubules drain into the collecting duct. So fluids that are filtrated in here in the corpuscle will go through this series of tubules, and then you will have several changes, including removing water, keeping electrolytes or absorbing electrolytes. So you will have absorption, secretion, filtration process, and the fluid that runs here in these renal tubules will be called filtrate, or sorry, tubular fluid. But it's up to when it reaches the collecting duct, where you call it urine. And we will see details about how all of these processes happens, but there are modifications that are done to this tubular fluid and even the urine according to needs. So for instance, if someone is over dehydrated, you can still pull water. That's called reclamation to maintain blood volume. And then that leads to the urine to be so concentrated. So now in the renal corpuscle, so we have the glomerulus that are fenestrated capillaries, and you have this filtration membrane that it is made by the wall of these capillaries, the basement membrane, and the capsule of the glomerulus. So it has a visceral layer, and then it has a parietal layer. So that parietal layer is simple squamous epithelium, and the visceral layer has some cells that are called podocytes because they look like little feet. And they have extensions of the cytoplasm and the plasma membrane that are called the pedicells. And they form filtration slits that can open and close, allowing the passage of molecules. Now, nothing greater than albumin size is supposed to cross these filtration slits. Albumin, if you remember, it's a very abundant protein that we have in the blood, and it helps to maintain the fluids within the circulatory system. Amino acids can cross through these filtration slits, but no complete proteins. And then we have a space between the parietal and the visceral layers of this capsule, which is called glomerular capsule or capsule of Bowman's, that is called the capsular space into which the filtrate it is captured so that it can now be transferred into the tubules, forming the tubular fluid. So then this is the microscopic anatomy of the renal corpuscle. So here we have the afferent arteriole, which is wider in diameter than the efferent arteriole. And then it makes this tuft of capillaries, which is called the glomerulus. And then the glomerulus will be surrounded by these podocytes, which forms the visceral layer of the capsule. And now here we have the parietal layer of the capsule, which is made by this simple squamous epithelium. And then in between the visceral layer, or the podocytes, and the parietal layer, we have the capsular space. So as blood is coming in, it's filtrated, and then that filtrate goes here into the capsular space, and then that filtrate is passing into this tubule, which is called proximal tubule. So this is a scanning electron micrograph of this area. So here is the main part of the podocytes. This is the body of the podocyte cells, and these will be the petty cells, like the little toes. And then they form filtration slits. So the molecules are filtered through here. Questions? Okay, so just keep in mind these two diameters for the arterioles. This is smaller, this is bigger. So more blood comes in than whatever comes out. So that creates pressure. It's like when you open a water hose and maybe there's not so much pressure in the water during the day. So what would you do to reach more distance with the water? You would close the ending of the hose, or maybe you compress a little bit the ending. So that allows more pressure to come out. So that builds up pressure, so that helps us to filtrate the building up of pressure. Now for the tubules are subdivided into segments. The first segment, the segment that is close to the corpuscle, will be the proximal convoluted tubule, or PCT. The intermediate segment that makes like a U shape, that will be the nephron loop, or the loop of Henle. And the loop of Henle has an ascending limb and a descending limb. The descending limb is close to the proximal convoluted tubule. The ascending limb is close to the distal convoluted tubule. And then in the proximal convoluted tubule, we have this epithelium, simple cuboidal with a lot of microvilli. Who remembers what is the function of microvilli in cells? That would be cilia, right? Cilia, it's a little bit longer than microvilli. Microvilli are tiny finger-like projections, but it's similar to cilia, but not the function, but structurally.
Sensory, isn't that how it understands its surrounding?
Surface. You increase the surface area with microvilli, but what you're trying to do, for instance, we have in the intestinal cells, we have microvilli. Sensory can be one function, movement as well, but the primary function of microvilli. Why do you want microvilli in your intestinal cells? What do we do in the intestinal cells? We digest, but we don't digest there, right? So what is the part of digestion that happens in the intestinal cells?
Breaking down.
Digestion, it means breaking down, right? So yeah, you have enzymes there that break down proteins into amino acids, individual amino acids, you absorb. So what's the function?
Absorption.
Absorption. I almost let it out. So it's for absorption. So then in this PCT, we have a bunch of microvilli because that's the area where we most absorb in the kidneys. Okay? So that increases the surface area to absorb more. And now for the loop of Henle, we have a thin descending limb where you have simple squamous epithelium. And then we have a thin ascending limb, which he has thicker simple cuboidal epithelium. So in here we have faster transport molecules in this simple squamous epithelium. And in here, we have transport, but not as much because of the difference in thickness. So this one is thicker than this one. Now we have a distal tubule, which is distal convoluted tubule, or DCT, where we also have simple cuboidal epithelia, and we have microvilli, but not as much as in the PCT. Okay? And then for the structural differences. So here we have different regions of these tubules. So this is a PCT. This is the descending limb. This is the thin descending limb. This is the thick. This is the ascending limb. This is the loop. This is the thin ascending limb. This is the thick ascending limb. And this is the DCT, or distal convoluted tubule. So if you magnify these different regions, this is how the epithelium looks like. So here in the PCT, it's cuboidal cells. They look like a square, and they have microvilli. And it's only one layer. That's why it's simple. So simple cuboidal epithelium with microvilli. And then in here, in the thin descending limb, we have simple squamous epithelium. And then in the thick ascending limb, we have simple cuboidal epithelium with no microvilli. So we don't absorb things in here. And then in the PCT, we have simple cuboidal epithelium, but very few microvilli. So yes, we can absorb here, but less than here. And then in here we don't absorb, and then in here we don't absorb. We secrete, or we transport by simple diffusion, but not absorption, okay? And now for this area, so this is the renal corpuscle, you're looking here. This is the renal corpuscle, this is the glomerulus, this is the capsular space, this is a parietal capsule. And then here we have the distal tubule, and we have this efferent arteriole, the afferent arteriole, and this space between the afferent, and this distal tubule, we have some cells that are called the juxtaglomerular cells in here, and the macula densa cells in here. So the macula densa cells are part of the distal tubule, and the juxtaglomerular cells are part of this space between the efferent and the afferent arteriole. So all together, the juxtaglomerular cells and the macula densa cells are the juxtaglomerular apparatus. Juxta means nearby. So it's the apparatus nearby the glomerulus. So we have here these smooth muscle cells in these afferent and efferent arterioles that helps to sense how much blood supply goes. So it sends basically blood pressure. And when blood pressure drops, these cells in here start secreting renin, the enzyme that helps to start a cascade so that we can increase blood pressure. And that regulates how much filtration happens in here, in this area. So those are details of the tubules. Now, details about the collecting system. So the collecting system is made by these collecting ducts, and we have collecting ducts that are near to the cortex, so this will be the cortical collecting duct. And in these ducts, we have simple cuboidal epithelium, and they drain several nephrons. Now, we have as well, in the medulla, in the pyramids, the medullary collecting system. that is the same as tubules with this epithelium, the simple cuboidal epithelium, and they merge all of these to form the papillary ducts that drains the urine into the papilla. And these papillary ducts have low columnar epithelium. So they are located at the end of these papillary ducts. So here we have a collecting system. So it's a single tubule, but when it's located here in the cortex, so this area is the cortex, represent the cortex. So this will be the cortical collecting system. And several nephrons drains into this collecting system. If you magnify, this epithelium will be simple cuboidal with few microvilli. Can you absorb items in here, in the collecting system? Yes. Why? Because you have the microvilli. And now here in the renal medulla, we have the medullary collecting system that same receives the fluid from several nephrons. And then if you magnify, the epithelium is low columnar with very few microvilli. Can you still absorb items in here? Yes, because you have microvilli. And again, this is just for protection. Normally we don't absorb, but only when someone is dehydrated, because it's kind of like the desperate measure of reclaimed water. Now, problems that can happen with the kidneys. So we can have development of kidney stones, which we call nephrolithiasis. Every time that you hear the word nephro, it means related to the kidneys. So most of these kidney stones are made out of crystal that is called calcium oxalate. And they can damage the kidney, the tubules, because they have like little spicules. And sometimes you can also have other items in these calculi or these stones, like uric acid. And this happens because you supersaturate these molecules in your body. Sometimes it can be risk factors like having a diet that is rich in proteins, fat, salt, and also poor intake of water. So some of these, they can be so large that they cannot go to this collecting system. They have to be broken down with lithotripsy. And one way to diagnose it is by giving the person contrast material, drink it, and then as the person passes this contrast material to the kidneys, you take imaging studies so you can see some obstruction. So the contrast material doesn't go through because you have a calculus here. And then here is the urinary bladder half full with this contrast material. Now, when the person passes this, in this case, this calculus is located here in the renal pelvis, almost going to the ureter. When it's passing through this ureter has smooth muscle cells. And then as this stone is passing by through here, one of these reflexes of the body, especially if it has spicules that is damaging the walls of the ureter, is to contract powerfully this smooth muscle cell. And then this is what is called the renal colic. It's very strong, the pain, and then the person might have sweating, nausea, and vomiting. And if he has damage to this internal epithelium and then down into the submucosa, the person will have bleeding, so the person will have blood. And this imaging study is called, in this case, they injected the material intravenously. Actually, it's done intravenously, not dreamt. So this is what we call intravenous pyelogram, or IVP. Questions? Comments? Right. Now let's look again at the differences between these nephrons, the cortical and the juxtamedullary. So in terms of abundance, 80% of the nephrons are located in the cortex, so they make 80%. The rest will be juxtamedullary. So these ones have a short nephron loop again that may never leave the cortex. While these ones, the juxtamedullary nephrons, they have a very long loop that goes from the cortex into the medulla, and it forms like a ladder network of capillaries that it is called, well, it has, not, sorry, it doesn't make, it has around this nephron, this part of the nephron, the loop, it has a network of capillaries that surrounds it that is called the vasa recta. So the peritubular capillaries surrounds the tubules in the cortical nephrons, while in the juxtamedullary nephrons, it is the vasa recta. So here we have a cortical nephron, and here we have a juxtamedullary nephron. Short looping here with these peritubular capillaries, long looping here with this vasa recta. And then something that happens with these long nephrons, long loops, is that we have better chances to concentrate urine than with this. Most of the times, we don't need to concentrate the urine because we, for the most part, are well hydrated. So then these ones are the ones that produce most of the urine. But in case that we need to concentrate it, we use these ones, the juxtamedullary, because we create gradients of sodium chloride around these loops that helps to absorb or not absorb water, depending on the situation. Now for the physiology of the urinary system. So we have glomerular filtration. Glomerular filtration happens in the glomerulus, in the glomerular capsule. So we have then these physical forces, oncotic, hydrostatic pressure, that drives the fluid from the glomerulus into the glomerular space. And then the fluid that results of filtration is known as filtrate. So first you have to bring, of course, the blood into the afferent arteriole, and then you filtrate it, and then the blood goes through the efferent arteriole. The other process that happens to form urine will be tubular reabsorption. So once the filtrate moves from the glomerular capsule into the PCT, now it's going to be called tubular fluid. And then in the tubular fluid, you will have a lot of the items that were filtrated, like, for instance, glucose, amino acids, electrolytes, vitamins, hormones, etc. All that the body requires back, it will reabsorb it in the PCT mainly. And fluid will keep going along the loop and along the distal tubule, and you can still have some reabsorption in these areas, but it is not as maximum as it happens in the PCT. And all of this happens as the fluid is passing by. And then once the fluid reaches the collecting system, you will have extra reabsorption, but that will be under the influence of hormones like ADH or aldosterone, depending on what are the needs of the body. And anything that we don't need is going to be secreted. Now, some of the items that we secrete will be reclaimed back depending. It can look like a waste of time, or waste of energy to do that. But no, maybe the body will, as the processes in our body is going through, maybe something that we secrete, we need to bring it back, and that's how we maintain electrolyte and acid-base balance through this process of secretion, as well with reabsorption. I compare these as when you're going to have a yard sale, right? You have spring cleaning, you have collected a bunch of items during the year, and then you have a bunch of boxes, and you start sorting. Well, this is going to be for sale, this is going to be for donation if it doesn't sell, or, well, this is going to be for donation, this is going to be for sale. And out of the items that you have for sale, the ones that are not sold, you can either put them in the pile of donation, or you can keep it. If you keep it, you are reclaiming. You need it. Maybe something that apparently you didn't have sentimental value for, but one of your kids see it in the box, and no, that's the toy that I like, and then it goes back. And then when the kid doesn't look, then you put it in the donation box and then you take it away. No, don't do that. Well, that's how we end up with a bunch of things, right? But anyway, it's so sentimental. So these are the three physiological processes then all together. So anything in this arrow means filtration, the purple arrow. R is with the green arrow will be reabsorption. And then this S with the red arrow means secretion. So the glomerulus definitely just send items into the tubules, like the filtrate has amino acids, glucose, water, vitamins, etc. It goes to the tubules, and then that's where you start sorting things. So areas where we reabsorb PCT in the thick descending limb of the loop, and also in the thin descending limb, and the thick ascending limb, but not in the thin descending limb, because we don't have microvilli, remember. And then here in the distal tubule, we also reabsorb because we have free microvilli, and then we can secrete both in the PCT and the DCT, and as well in the collecting duct. And as well, we can reabsorb in here. Some of the drugs that people ingest can go into the process of reabsorption and then secretion later on, and in here. Because they can be metabolized further. That's why you can reabsorb them in here, and then later on, after they've been metabolized, they end up in urine. That's how many people, they can achieve those urine tests. Because in here, once they are secreted, there is no way that they can go back into the body. Like steroids and all those that they use for competing in sports events. So details about the filtration membrane that we have in the glomerulus. So just like as the respiratory membrane, we have a membrane with 3 layers. 2 epithelial layers sandwiching a basement membrane. So we have the wall of the capillaries, which is fenestrated, and this fenestrate or pores, they have between 70 to 100 nanometers in diameter. So blood cells and platelets cannot leave this glomerulus because this space is very small. Now, in the basal lamina or the basement membrane, we have collagen fibers and these other proteins from the extracellular matrix that has negative charges, and that prevents any molecule greater than 8 nanometers of diameter, like for instance albumin, which has negative charge and it has a size of 10 nanometers, it cannot live because it has 8 nanometers in diameter. Now, then proteins shouldn't go out of this basal lamina. Now the next part, which is the visceral layer of the glomerular capsule, the podocytes, with these pedicels, they prevent molecules that are less than 6 to 7 nanometers in diameter to escape. Sorry, I was saying that albumin was 10 nanometers in diameter, it's actually 7.1. So then albumin shouldn't be in the filtrate, nor red blood cells, no white blood cells, no platelets, no proteins. Amino acids can go through, but no complete proteins. Sometimes it happens because a person might have damage to this membrane, which is glomerulonephritis. They can have big gaps in the glomerulus, and then they have escape of these proteins. So this will be proteinuria. And then the person will lose oncotic pressure. So since it doesn't have as many proteins in the blood, then the fluids of the person, instead of being in the circulatory system, go into the tissues, and the person has edema. The person looks puffy. And there are several causes for glomerulonephritis. So, but then this filtration membrane, it is very important then to keep our circulatory system with enough volume, and also to keep red blood cells, white blood cells in our body. So we shouldn't have those escaping from our body. And then the amount of or the percentage of plasma that becomes filtrate is called filtration fraction. So the average is 20% of combined surface area of the kidneys, this filtrate that comes from all of these filtration. So we have around 6 square meters of these membranes, the filtration membrane, and that leads us to a filtration fraction of 20%. So out of all the blood that we receive, we have a filtration fraction of 20%. So then what is found in the filtrate? Water, majorly, small solutes, like hormones maybe, small proteins, amino acids, glucose, and electrolytes, which will be calcium, sodium, potassium. Sometimes we can have vitamins, depending on what is your nutritional state. And of course, we can have wastes, like nitrogenous wastes coming from the metabolism of proteins, which is urea and ammonium ions. And we can have a waste product that we call creatinine, which comes from metabolism of muscle, and uric acid that comes from metabolizing nucleic acids. So those are all the things that we can find in the filtrate. So here is, again, our renal corpuscle. So we're going to look at this area. Now we're looking at the ultrastructure. So if you magnify this, you will be able to see, if you cut the pedicels, And the podocytes, you will be able to see the fenestrae. So this is the wall of the capillaries. So these are the gaps. Inside you have, of course, white blood cells, red blood cells, plasma, and then all the molecules that we have in plasma, electrolytes, vitamins, hormones, etc. And then we have here a layer in between, which is the basal lamina with these proteins, collagen fibers, and then outside we have the petty cells. So then we have negative charges, which forms a electrical barrier, and then we have these physical barriers. So the fenestrae, and then the gaps between the petty cells. And any small molecules can come in, but no large molecules. So everything's supposed to be out. And what carries these molecules? Water. Water comes out into this space. Sometimes I compare this membrane as when you are making coffee with the old-fashioned, like not these pots. So then you have this holder for the filters, and then you put your ground coffee. Sometimes you can put one filter, some people put two. And if you put two, that will represent the wall of the capillaries and the capsular visceral layer. And then your ground coffee has certain size, and the pores of your filter as well certain size. So you're supposed to have water with the flavor of coffee, but not grounds in your coffee. But what will happen if you grab a pin and you start making holes, and large holes? Well, the grounds will go into the filter, right? So that's what happens with glomerulonephritis. You can have large gaps here, and you have escape of erythrocytes, leukocytes, proteins. And then you end up with losing a lot of good things. The efficiency of filtration of the kidneys is measured by the GFR, glomerular filtration rate. Typically, we filter 125 millimeters of blood per minute. We form 125 millimeters of filtrate per minute when we are filtrating this. What I want? Wait a second. 125 millimeters of blood are filtrate per minute. If you multiply that times the number of minutes per day, that leaves you to around 180 liters of filtrate per day. So then, of course, we don't urinate 180, right, liters. But because we absorb most of the filtrate, and that filtrate that we do per minute is the result of these pressures. We have hydrostatic pressure and colloid osmotic pressure. Now, we have colloid osmotic pressure only inside the capillaries because that's where we have albumin and all the proteins. But we have hydrostatic pressure both in the capillaries and also in the capsular space because we have water in both sides. And unless someone has glomerulonephritis, of course, proteins will go into the capsular space, but let's talk about the normal. So then, since we only have proteins inside the capillaries, that's where we have the colloid osmotic pressure. And the colloid osmotic pressure opposes the hydrostatic pressure. While hydrostatic pressure tends to make the fluids to go out of the capillaries, oncotic pressure makes the fluids come in. So they are antagonistic pressures. Then when you basically take into account what is the pressure in millimeters of mercury of each of these, and then you subtract them, you end up with NFP, or net filtration pressure. Now, the hydrostatic pressure then that we have in the glomerulus, or GHP, is 50 millimeters of mercury. And now the proteins that makes the glomerular colloid osmotic pressure, or GCOP, makes 30 millimeters of mercury. So then we have higher hydrostatic pressure, 50 versus 30. What is the difference? 20. Because of that, then fluid tends to go out because of that gradient, because of those 20 millimeters of mercury. Now, if you take into account that in the capsular space we have hydrostatic pressure, which is CHP, which is 10, then that opposes the fluid coming out. So in that case, you add that to those 30 millimeters of mercury from the colloid hydrostatic pressure. So they will be 30 plus 10, 40, and then 50 of the glomerular hydrostatic pressure minus 40, that gives you 10 millimeters of mercury. That will be the NFP, net filtration pressure. With that 10, that's where you form your 125 millimeters of mercury. Sorry, milliliters, not millimeters. 125 milliliters of filtrate per minute. That's your GFR. So this is how we visualize it. So then inside the glomerulus, we have GHP, and then we have GCOP, proteins and water. So this one forces the hydrostatic pressure fluid out into the capsular space, which will be this one. So that's 50 millimeters of mercury. And then the colloid osmotic pressure pulls fluid from the capsular space into the capillaries. So 50 minus 30, that would be 20. And then since we have water here in this capsular space, that it is opposing this, so then you have 20 minus 10, that's 10. That's your net filtration pressure. So then you have overall filtration. Questions? And then I already mentioned you about glomerulonephritis. So it involves damage and destruction of the glomeruli. Sometimes it can be due to antibodies that get trapped in there with molecules, and then the neutrophils comes, and then they start destroying these glomerulus, and then you have sometimes damage so much that you have accumulation of toxic molecules in your blood. And then if it's so severe, it can lead to renal failure, in which you don't urinate as much as we're supposed to. Okay, so this is all for this part. Do you have any questions?